Friday, September 8th, 2023, AGNDD Intellireport topic: Attention Deficit Hyperactivity Disorder. Please pardon any visual and informational inaccuracies in this entirely AI-generated Wikipedia-sourced video article.
ADHD, or Attention Deficit/Hyperactivity Disorder, is a neurodevelopmental disorder characterized by symptoms such as inattention, hyperactivity, and impulsivity. These symptoms can have a significant impact on academic performance, relationships, and overall functioning. ADHD is characterized by symptoms such as inattention, hyperactivity, disruptive behavior, and impulsivity. These symptoms can lead to academic difficulties and problems in relationships. It can be challenging to determine the line between normal levels of these behaviors and levels that require intervention. Studies have shown that individuals with ADHD have an increased risk of accidents and traffic collisions. The Diagnostic and Statistical Manual of Mental Disorders, DSM-5, outlines specific criteria for diagnosing ADHD, including the duration and impact of symptoms. ADHD is categorized into three main presentations: predominantly inattentive, predominantly hyperactive impulsive, and combined type. Symptoms of ADHD can vary based on age and gender, with girls and women typically displaying more symptoms of inattention and distractibility. As individuals with ADHD age, hyperactivity may become less overt and manifest as inner restlessness or constant mental activity. Impulsivity in adulthood can appear as thoughtless behavior, impatience, and irresponsible spending. Difficulties with social skills, language processing, anger management, and motor development are also common in individuals with ADHD. ADHD often occurs with other disorders in children, such as autism spectrum disorder, learning disabilities, intellectual disabilities, and Tourette's syndrome. It is also commonly comorbid with disruptive impulse control and conduct disorders like oppositional defiant disorder and conduct disorder. Anxiety disorders, mood disorders, especially bipolar disorder and major depressive disorder, and sleep disorders are frequent comorbidities as well. Substance use disorders, particularly alcohol and cannabis abuse, are also more common in individuals with ADHD. These comorbidities can complicate the evaluation and treatment of ADHD. ADHD, trauma, and adverse childhood experiences, ACEs, often coexist and share similar symptoms. The symptoms of ADHD and PTSD, such as restlessness, difficulty concentrating, irritability, and poor impulse control, can overlap. This can lead to misdiagnosis or confusion between trauma-related disorders and ADHD. Moreover, childhood trauma can increase the risk of developing ADHD due to brain changes. Lastly, the behavioral consequences of ADHD symptoms can increase the likelihood of experiencing trauma, further complicating the diagnosis. ADHD is often associated with comorbidities such as epilepsy, obesity, asthma, sleep disorders, celiac disease, and migraine headaches. There is no increased risk of tension-type headaches in children with ADHD, but medication can sometimes cause headaches. A recent review found that certain neurometabolic disorders share common neurochemical mechanisms with ADHD, emphasizing the need for collaboration between health services to prevent clinical overshadowing. Systematic reviews conducted in 2017 and 2020 found strong evidence linking ADHD to increased suicide risk across all age groups. A 2019 meta-analysis also indicated a significant association between ADHD and suicidal behaviors. However, the relationship between ADHD and suicidality is still unclear due to mixed findings across individual studies and the impact of comorbid psychiatric disorders. It is uncertain whether ADHD directly increases suicide risk or if it does so through comorbidities. Studies have found that individuals with ADHD tend to have lower scores on IQ tests, but the significance of this is controversial. Differences in symptoms and the influence of distractibility make it difficult to determine if lower scores are due to intellectual capacity or other factors. Some studies exclude individuals with lower IQs, leading to overrepresentation of higher IQs in ADHD studies. However, other studies suggest that individuals with high intelligence may be at risk of a missed ADHD diagnosis due to compensatory strategies. Studies of adults suggest that negative differences in intelligence may be explained by associated health problems. ADHD is believed to be caused by neurological dysfunction related to dopamine and norepinephrine in the brain, but the exact causes are not yet confirmed. It is likely a combination of genetic and environmental factors that contribute to the development of ADHD. ADHD has a high heritability of 74%, indicating that 74% of the occurrence of ADHD in the population is attributable to genetic factors. Multiple gene variants are involved, with each contributing slightly to the probability of having ADHD. Genes associated with dopamine neurotransmission like DAT, DRD4, and COMT are implicated. Additionally, genes such as SIRT, SNAP25, and BDNF are also linked to ADHD. Genetic variation can help predict an individual's response to stimulant medication, although no single gene can accurately predict ADHD. Furthermore, there is a genetic overlap between ADHD and autism spectrum disorder, ASD. ADHD can be influenced by both genetic and environmental factors. Environmental factors that may contribute to ADHD include alcohol intake during pregnancy, exposure to toxic substances like lead or polychlorinated biphenyls, exposure to certain insecticides, tobacco smoke during pregnancy, extreme premature birth or low birth weight, neglect or abuse, certain infections, traumatic brain injury, artificial food dyes or preservatives in some cases, and sensory overload. While factors like refined sugar, television, bad parenting, poverty, and family chaos do not cause ADHD, they may worsen symptoms in some individuals. Media use has also been found to have a small but significant relationship with ADHD-related behaviors in children and adolescents. Current models of ADHD suggest that it is associated with impairments in the brain's neurotransmitter systems, specifically dopamine and norepinephrine. These pathways, originating in the ventral tegmental area and locus coeruleus, affect various cognitive processes. The dopamine and norepinephrine pathways that project to the prefrontal cortex and striatum are responsible for executive function, motivation, reward perception, and motor function, all of which are affected in ADHD. Some larger models of ADHD include additional pathways. Children with ADHD have reduced volume in certain brain structures, particularly in the left-sided prefrontal cortex and posterior parietal cortex. Other brain structures in the prefrontal striatal cerebellar and prefrontal striatal thalamic circuits also differ between individuals with and without ADHD. Subcortical volumes of the accumbens, amygdala, caudate, hippocampus, and putamen are smaller in those with ADHD. Functional MRI studies have shown increased connectivity between subcortical and cortical regions in ADHD brains, with the degree of hyperconnectivity correlating with the severity of symptoms. Results on hemispheric lateralization processes in ADHD are conflicting. Previous theories suggested that the increased number of dopamine transporters in individuals with ADHD was a contributing factor to the condition. However, it is now believed that this increase may be a result of adaptation to stimulant medication. Current models focus on the involvement of the mesocorticolimbic dopamine pathway and the locus coeruleus noradrenergic system in ADHD. Psychostimulant medications used to treat ADHD are effective because they enhance neurotransmitter activity in these systems. Other neurotransmitter pathways such as serotonergic, glutamatergic, and cholinergic may also be affected in ADHD. ADHD is characterized by deficiencies in executive functions such as attentional control, inhibitory control, and working memory. These impairments lead to difficulties in organization, time management, concentration, and emotional regulation. People with ADHD may have unimpaired long-term memory but struggle with working memory. Symptoms may not fully manifest until adolescence or adulthood due to brain maturation. ADHD is also associated with motivational deficits, as individuals may struggle to prioritize long-term rewards over immediate gratification. The central nervous system in some individuals shows altered signal processing, as evidenced by a common paradoxical reaction in 10–20% of patients. These reactions are unexpected and opposite to the normal effect, or significantly different. They occur in response to neuroactive substances like local anesthetics, sedatives, caffeine, antihistamines, weak neuroleptics, and painkillers. Since these reactions have a genetic component, it may be helpful to inquire about similar abnormalities in family members, especially in critical situations like surgeries. ADHD is diagnosed through a comprehensive assessment of a person's behavior and mental development, ruling out other possible causes for the symptoms. Feedback from parents and teachers is often taken into account, with diagnoses typically initiated after concerns are raised by a teacher. Brain imaging studies are not consistent enough for diagnosis and are mainly used for research purposes. Different diagnostic criteria, such as DSM-5 and ICD-10, are used in different regions. ADHD is often associated with other conditions like anxiety, depression, and learning disorders. Self-rating scales and electroencephalography are used in the screening and evaluation process. ADHD is diagnosed based on specific criteria outlined in the DSM-5 and DSM-5-TR. There are 3 presentations of ADHD: predominantly inattentive type, predominantly hyperactive impulsive type, and combined type. To be diagnosed, individuals must meet a certain number of symptoms that have been present for at least 6 months and occur in multiple environments. The symptoms must also cause social, school, or work-related problems. There are also diagnoses for individuals who have ADHD symptoms but do not fully meet the criteria. In the 11th revision of the International Statistical Classification of Diseases and Related Health Problems, ICD-11, Attention Deficit Hyperactivity Disorder, ADHD, is classified with specific subtypes. These subtypes include predominantly inattentive presentation, predominantly hyperactive impulsive presentation, and combined presentation. There are also 2 residual categories for individuals who do not fit into any of the defined subtypes. In the 10th revision, ICD-10, the symptoms of hyperkinetic disorder were similar to ADHD, and when combined with conduct disorder, it was referred to as hyperkinetic conduct disorder. The social construct theory of ADHD suggests that the boundaries between normal and abnormal behavior are socially constructed, meaning they are determined by society and subjective judgments. This theory argues that the number of people diagnosed with ADHD can vary depending on the diagnostic criteria used. For example, using DSM-4 criteria could result in higher rates of diagnosis compared to using ICD-10 criteria. Supporters of this theory, like Thomas Zaz, believe that ADHD was created and named rather than being an inherent condition. Adults with ADHD are diagnosed using the same criteria as children, but the symptoms may present differently. It is estimated that 2.58% of adults have persistent ADHD, while 6.76% have symptomatic ADHD. Many adults with ADHD remain untreated and may have difficulties in various aspects of life. Associated mental health problems include depression, anxiety disorders, and learning disabilities. Some ADHD symptoms in adults include an inability to relax, excessive talking, impulsivity in relationships, sensation-seeking behavior, and addictive behaviors. Late-onset ADHD can occur in adolescence or early adulthood. The DSM-5 offers potential differential diagnoses for ADHD, which include ODD, intermittent explosive disorder, neurodevelopmental disorders, learning disorders, anxiety disorders, depressive disorders, bipolar disorder, substance use disorder, personality disorders, psychotic disorders, medication-induced symptoms, and neurocognitive disorders. Symptoms of ADHD can also be mistaken for dysthymia, cyclothymia, bipolar disorder, borderline personality disorder, anxiety disorders, developmental disabilities, intellectual disabilities, substance abuse, and medical conditions such as hyperthyroidism, seizure disorder, lead toxicity, hearing deficits, hepatic disease, sleep apnea, celiac disease, and head injury. Sleep problems can also impact ADHD symptoms. The management of ADHD typically involves counseling or medications, either alone or in combination. While treatment may improve long-term outcomes, it does not eliminate negative outcomes entirely. Medications used include stimulants, atomoxetine, alpha-2 adrenergic receptor agonists, and sometimes antidepressants. Positive reinforcement can improve task performance in those who struggle with focusing on long-term rewards. ADHD stimulants also improve persistence and task performance in children with ADHD. Recent evidence suggests that pharmacological treatment of ADHD is associated with increased achievement, decreased absenteeism at school, reduced risk of trauma-related emergency hospital visits, lower rates of suicide and attempted suicide, and decreased rates of substance abuse and criminality. Behavioral therapies are recommended as the first-line treatment for ADHD, especially for those with mild symptoms or who are preschool-aged. Various psychological therapies, such as psychoeducation, behavior therapy, cognitive behavioral therapy, and family therapy, can be effective in managing ADHD symptoms. Neurofeedback has shown positive treatment effects, but there is a lack of regulation in its practice. Parent training, family therapy, and support groups can also be beneficial in managing ADHD. Social skills training, behavioral modification, and medication may have limited positive effects on peer relationships. Methylphenidate and amphetamine are commonly used as first-line treatments for ADHD due to their effectiveness. Stimulants like these have been found to reduce the risk of unintentional injuries in children with ADHD and can improve brain structure and function. Insomnia is a common side effect of stimulant medication, and other side effects like decreased appetite and weight loss may also occur. Long-term effects of ADHD medication are still being studied, but stimulants are generally considered safe for up to 2 years. Nicotine and caffeine have shown some positive results in treating ADHD, while pseudoephedrine and ephedrine do not affect symptoms. Modafinil may also be used off-label to treat ADHD. There are several non-stimulant medications that can be used as alternatives or in addition to stimulant therapy for ADHD. These include viloxazine, atomoxetine, bupropion, guanfacine, amantadine, and clonidine. While there are no definitive studies comparing these medications, they generally have similar side effects. Stimulants have been found to improve academic performance in children, while atomoxetine does not. Atomoxetine may be preferred for individuals at risk of stimulant misuse. Amantadine has shown similar improvements to methylphenidate with fewer side effects. Antipsychotics may also be used for aggression in ADHD. Guidelines for medication use differ between countries. In the UK, medications are recommended for children only in severe cases, while for adults they are a first-line treatment. In the US, medications are recommended for most age groups, but not for preschool children. Underdosing of stimulants can lead to a lack of response or loss of effectiveness, especially in adolescents and adults. Approved dosing is based on school-age children, leading some practitioners to use weight-based or benefit-based off-label dosing. Regular aerobic exercise has been found to be an effective additional treatment for ADHD in both children and adults. When combined with stimulant medication, exercise can lead to improved behavior, motor abilities, executive functions, information processing speed, and memory. Parent and teacher ratings also show positive outcomes such as better overall function, reduced ADHD symptoms, improved self-esteem, decreased anxiety and depression, fewer physical complaints, better academic and classroom behavior, and improved social behavior. Exercising while on medication enhances the medication's effect on executive function, and it is believed that exercise increases dopamine and norepinephrine levels in the brain, leading to these positive effects. Dietary modifications are not recommended as a primary treatment for ADHD, according to various organizations. Studies have shown limited benefits from supplements or eliminating certain foods, and these benefits may only apply to children with specific sensitivities or those already on medication. Elimination diets may have a small benefit for children with allergies. Gluten-free diets are not advised as standard treatment. Deficiencies in iron, magnesium, iodine, and zinc may impact ADHD symptoms, but zinc supplementation is not recommended unless there is a demonstrated deficiency. ADHD can persist into adulthood in 30 to 50% of cases, but individuals often develop coping mechanisms to compensate for their symptoms. Children with ADHD have a higher risk of unintentional injuries, but medication can help reduce functional impairment and improve quality of life. Rates of smoking and ADHD prevalence are higher among prison populations, with estimates ranging from 25.5% to 40%. ADHD is more common among longer-term inmates. ADHD is estimated to affect around 6-7% of people aged 18 and under when diagnosed using DSM-4 criteria, and 1-2% when diagnosed using ICD-10 criteria. Rates of diagnosis are higher in North America compared to Africa and the Middle East, likely due to differences in diagnostic methods. ADHD is diagnosed more frequently in boys than in girls, but this may be due to underdiagnosis in girls. Rates of diagnosis and treatment have increased since the 1970s, possibly due to changes in diagnostic criteria and attitudes towards medication. Disparities in diagnosis and understanding of ADHD exist between Caucasian and non-Caucasian populations, leading to underdiagnosis and misdiagnosis. Cross-cultural differences in diagnosis can also be influenced by historical racial biases and mistrust of medical practices. Stereotyping and differences in symptom presentation can contribute to misdiagnosis in non-Caucasian individuals. The history of ADHD dates back to the late 18th century, with Sir Alexander Crichton describing mental restlessness in his book. The first clear description of ADHD was credited to George Still in 1902. Over time, the terminology and classification of ADHD have evolved, with the DSM-3 introducing the term ADHD in 1987. Stimulant medications like benzodrine and methylphenidate were first used in the 1930s and 1950s, respectively. Neuroimaging studies in the 1990s supported the theory of neurological differences in ADHD, and a genetic component was also identified. The current subtypes of ADHD were established through a field trial. ADHD diagnosis and treatment have been controversial since the 1970s, with differing views on its nature and causes. Controversies include the use of medication, overdiagnosis, and cultural factors influencing diagnosis. Some argue that ADHD is a genuine disorder, while others see it as a medicalization of deviant behavior. Treatment efficacy is often measured by reductions in symptoms, but subjective ratings from teachers and parents are sometimes included. Studies have also shown differences in diagnosis patterns based on birth dates, suggesting subjective analysis in ADHD diagnosis. ADHD symptoms such as diffuse attention, flexible associative memory, and impulsivity may contribute to increased creativity in terms of divergent thinking and quantity of creative achievements. However, individuals with ADHD may struggle with convergent thinking and focusing on a single solution. Historical documentation suggests that Leonardo da Vinci's difficulties with procrastination and task jumping may be characteristic of ADHD. Overall, ADHD may have some positive traits related to creativity, but further research is needed. Reviews of ADHD biomarkers have found that certain measurements such as platelet monoamine oxidase, expression, and urinary levels of norepinephrine, MHPG, and phenethylamine consistently differ between individuals with ADHD and those without. These measurements could potentially be used as diagnostic biomarkers for ADHD, but more research is needed to confirm their diagnostic usefulness. Additionally, lower urinary and blood plasma phenethylamine concentrations are observed in individuals with ADHD, and the commonly prescribed drugs for ADHD, amphetamine and methylphenidate, can increase phenethylamine production in responsive individuals. Lower urinary phenethylamine levels are also associated with inattentiveness symptoms in ADHD individuals. In conclusion, ADHD is a complex disorder that can have a significant impact on various aspects of an individual's life. It is important to recognize the symptoms and seek appropriate intervention to help manage the challenges associated with ADHD.
Thank you for watching this AGNDD Intellireport. Like, subscribe, and click the bell button to get notified during new uploads. And make sure to tune in next time. Stay safe and healthy. Cheers.